Welcome back after the break. We're going to move on with another talk. This is from Meronike Oluwatoyin-Falayan, who's from the Abafemi Awolowo University in Nigeria. She is the Professor of Pediatric Dentistry at that institution and also holds the Fellowship of the West African College of Surgeons. She has a history of working with the community for the community to enhance the voices of stigmatized and vulnerable populations. We really look forward to your presentation.
Good afternoon, everyone. It's a pleasure to be here. In the next 15 minutes, I'll be discussing reduction of stigma and discrimination in health systems and service delivery. My examples will be based mainly on my experience in Nigeria. I will be using this outline. First, I'll be introducing the concept of health systems as well as healthcare delivery. I will discuss ways that stigma is expressed in health settings, as well as drivers of stigma. I will also share some stigma reduction strategies and then provide a summary of my discussion and then conclude. As an introduction, stigma labeling, separating and discrimination, which we know is along a line of spectrum of stigma enactment, can be enacted throughout the health system. And it's critical to know that the systems that support promotion, restoration, and maintenance of health may be also systems through which stigma is enacted. It is also very important to appreciate that stigma can be enacted through inequitable organizations of persons, institutions, and resources that support healthcare delivery systems. And throughout this conference, I'm sure, and in the last few hours leading up to my talk, you would have heard how inequitable organizations of people, institutions, and resources have informed stigma and its practice in healthcare delivery. For me, one critical example of how organized institutional practices enact stigma is the separation of care systems for people living with HIV as opposed to people not living with HIV. In those systems where people living with HIV have separate systems, mechanism of assessing care, as opposed to people not living with HIV, that system itself helps to point to people living with HIV who are the minority of the population to stigma processes, stigma enactment, because they are viewed as an order. And as I go on in my presentation, you would also learn how the communication of authors, either in our expressed language, verbal or non-verbally, also helps to institute stigma. For me, one also critical examples that I've been battling with in my country includes institutionalization of care system for key populations. In Nigeria, we have what is called one-stop shop, otherwise known as sexual health clinics that operationalize or provide care for female sex workers, men who have sex with women, as well as people who inject drugs. The reason why this one-stop shop were institutionalized in the first place was because the public health systems and for many private healthcare systems discriminate against people who are key pops. And therefore, in a bid to address that, they created these clinics. Further, for me, as by my own perception, is only a mechanism of institutionalizing stigma, because there aren't invested mechanisms to address the public system to be able to provide equitable care for people who are considered K-pops. And therefore, we had gone ahead to address discrimination in the public health system, creating a system that supports people, K-pops through the one-stop shop. Why this is a problem is because these one-stop shops are funded by donor agencies, which means people living with HIV are not provided care by government funding. They are not resourced. And therefore, the day that donor funding dries up, one-stop shops then disappear. But the sad thing is that because there's a one-stop shop, there is an investment in the process of making public health institutions key population friendly. The result, once donor funding dries up, one-stop shop goes, and therefore we lose the potential of integrated care for key populations in the public health center. So this is, for me, an example of an inequitably organized system and resourcing of healthcare delivery that in itself institutionalizes stigma. We also are aware that in healthcare setting, the institution of stigma is not only related to diseases or health, but it can also be driven by non-health related stigma. We're very aware of HIV-related stigma, but also other diseases like epilepsy, disability, leprosy, mental health, and substance abuse. But also in these healthcare systems, we have non-health related stigma. Stigma based on race, ethnicity, maybe K-pop or LGBTI population are also stigmatized. But for me, my key message at this time is that stigma is a learned culture of practice, which therefore results in unjust separation. What does this mean? For me, it's a culture that is learned. That means it's a group of persons who practice it. One person does not practice stigma and thereby institutionalize it. It's because there's a group of people that have this common norm, common value, common system that allows stigma to be practiced. And therefore, if we are going to address stigma, which I think can be unlearned, it would involve disrupting that group of stigma. And why is it important that we disrupt this process in the health setting? It is because stigma expressed in the health setting undermines the delivery of quality health care. In addition, it also limits the ability of clients to achieve optimal health care. That for me is a huge concern, because where the public health system is supposed to be providing care for the majority, where clients cannot access that quality care in the public healthcare system, where the government has invested resources to ensure quality of care delivery, people then access care in the alternative system that is not properly resourced, that is not properly monitored, that the capacity and competency is not properly built. In effect, because of stigma, people are driven into systems of care that otherwise undermines their mobility as well as risk for morbidity and mortality. It's also a concern because people face stigma at the most vulnerable point of their life, when they need health care. And it therefore makes people feel dehumanized. And I think for us, it's a huge concern, and therefore something that we need to address. We also have to be aware that stigma does not only affect clients. Healthcare workers themselves can also be impacted negatively by stigma. And when healthcare persons cannot access care because they do not want to identify with the stigmatized conditions, either because they are diseased like HIV, it also therefore undermines their own competency to provide optimal care and services to clients. In effect, my second critical message is that discrimination deprives people of their right. And if we're going to tackle stigma in the healthcare setting, we have to promote human rights using human rights approaches. And I'm sure for many, this rings a bell, because in many systems, in the healthcare systems in Africa, the approach is a public health approach and less to a human rights-based approach. There are very many ways that stigma is expressed in the healthcare setting, ranging from outright denial of care to provision of substandard care by passing care of stigmatized persons to junior persons in the system, because you don't want to handle the person and increasing the risk of the person to have suboptimal care, physical abuse, verbal abuse, or making persons wait longer because you truly do not want to give them the necessary attention. Throughout this last few hours in this conference, you've heard of the means of expressing stigma, of the way people have also felt stigmatized in healthcare setting. But then we have drivers of stigma. One very common driver is the negative attitude resulting from poor knowledge of disease management, myths and misconception. And for many of us during this COVID epidemic, we would remember what it really means. People have been stigmatized because of fear of infection, because of poor knowledge of managing COVID-19. And therefore, you've had discriminatory practices. In my own institution, one of the discriminatory practices that have been institutionalized, and something we've been fighting and battling with, but the minority of us that had also fought in the during the HIV epidemic, is having all patients, take a COVID test because the doctors are concerned about being infected. Some of us that are listening here, you'll be very familiar with this, because in the HIV epidemic area, early days of the HIV epidemic, all patients also required to take an HIV test because doctors were afraid of getting infected from patients. And one of the strong ways we advocated against this is that patients also have rights. If therefore, because you're concerned about contracting infection from patients, patients have a right to be concerned about contracting infections from you. And therefore, you also have to have a test that you show to your own patients that tells you that you're disease-free. Having said that, isn't actually the way to go. It's about addressing for those that is poor knowledge that is resulting in institutional stigma, because fear and concerns is about addressing that fear and concern by education. But then our concern is the institutionalization of the practice, and that is where there is a problem, because even where the knowledge and knowledge is addressed, meets and misconception is addressed, the institutionalized process might take time for it to, be removed. And that in that time difference, people are impacted. Another reason is what I call being stigma blind. People are not aware that they are stigmatizing and it's an impact on people. And that might be because of, once again, the culture of practice. It is a culture because people normally, or it's a norm to disrespect human rights. They live in a system, they live in a world where the disrespect of human rights is a norm. And therefore, they do not see the impact, understand the impact of the fact that they're, enacting stigma. When you help people understand that, it might be a difference. Of course, we're aware that people might bring their moral bias from culture and religious into the healthcare setting. And that is really very common in Africa, where that morality makes you judge and then have the right to enact stigma. But for me, one of the strongest reasons why you have stigma is where there's no policy that elaborates on a zero tolerance to stigma. And there are no procedures and there are no practices that addresses. There's no procedures for seeking redress, and there are no practices for punishing persons that enact stigma. And this, for me, is very strong because I was involved in an institutional assessment that assessed people about their stigma for sexual minorities, or their values and their stigma, their potential to enact stigma for sexual minorities, as well as enact stigmas for people living with HIV. And I found in that organization that there were a significant number of persons who have values that could make them enact stigma. However, they would not enact because it was very clear in the institution that there was a zero tolerance policy for stigma. There were procedures set in for people to seek redress for stigma, and you would lose your job once it is proven that you're stigmatized. And therefore, there was no single recorded evidence of people reporting about being stigmatized or their sexual orientation or for their HIV status. And for me, I think that's a very, very powerful tool that sadly many public health institutions in Africa do not use. A third message for me in the session is the place of use of language. The way we use languages also helps us institutionalize the order of difference. When we consistently refer to a population of they are always a they. And when you refer to people as they often are the minority. And therefore, you institutionalize a process of power that distinguishes a minor they that is different from the major we. And therefore, you have a right to treat negatively the minorities of they. And I think at an individual level, beyond the health systems and health delivery care processes, we have to help people learn how to communicate rightly, where we don't distinct people as a they and we. Stigma reduction strategies. Lucia and her group published an excellent article in BMC Medicine in 2019, and I refer persons to read the article. I found it very educating. They conducted a systematic review of 42 published articles that identified 6 intervention strategies, which include provision of information that addresses myths and misconception and poor knowledge. They identified skills-building activities to facilitate work with people, participatory learning approaches, contact with stigmatized populations to promote empathy. They also identified empowerment to improve client coping mechanisms. And finally, the institutional structural changes, including policy changes that promote redress when people face stigma. And they noted that many institutions use multiple strategies, not one, but multiple strategies, and it did not find any particular strategy was superior to the other. And therefore, when we're talking about stigma reduction approaches, it will be very important that any of these approaches that we adopt, we institute them as part of routine healthcare delivery system. But more importantly, that the health system's monitoring processes must also assess for stigma. Where they assess for stigma, they can identify where it's enacted and therefore institute practices that will address that. For the long term, it's very important that stigma reduction approaches be integrated into pre-service and in-service training of healthcare providers, either clinicians and non-clinicians. And for me, one of my strongest messages is that we need to evolve from running our healthcare delivery system based on a public health approach only to one that recognizes and institutes a human right-based healthcare delivery approach. This will help address stigma and any other rights breaching practices in our health system. It is also very important that whatever approaches we adopt, we must address the health system itself as well as the health delivery system. Integrating services is very important. And finally, please let us work towards using a common approach to address stigma in the health system. What I mean by this is that it is not enough to address HIV stigma, TB stigma, disability stigma, because one of the things you see is that all the stigma is driven by common underlying drivers. It is expressed in the same way for most times. So why not institute a system in the healthcare delivery or whichever health institution that addresses stigma across board rather than in silos, addressing them as silos, because the etiology of stigma, for most parts, is common across all. And of course, the context specificity of its expression. In summary, in the last 15 minutes thereabout, I've tried to highlight that stigma in the health setting can affect result from health and health-related reasons, or health and non-health related reasons, and it can affect both clients as well as the healthcare provider. It can be expressed as outright denial of care to physical and verbal abuse, which all together undermine the quality of care for clients. And I have tried to identify that there are many drivers, chief among which is the absence of institutionalized policies and practices against stigma. And that when we want to address them, whatever approaches we use, we have to use multiple interventions together that is directed at health systems as well as the providers in a bid to reduce or eliminate stigma. In conclusion, I would want to also recommend that context-specific implementation research that evaluates the cost-effectiveness of strategies for reducing stigma in healthcare services be conducted. We have very limited evidence in this respect. And the more evidence about the impact of stigma reduction strategies, the more it is for us to be able to adopt the strategy. And that as much as possible when we're instituting practices, we should use multiple strategies that target clinic and non-clinic staff, as well as health and non-health related stigma. And we should push for the institutionalization of stigma reduction and elimination practices. This is very important. And as much as possible, our elimination of discrimination, you use a holistic approach. At this point, I would like to say thank you for listening.